The quality of your history and physical examination lays the foundation for patient assessment, your recommendations for care, and your choices for further evaluation and testing. As you become an accomplished clinician, you will continually polish these important skills. With practice, you will meet the challenge of integrating the essential elements of clinical care. They include empathetic listening, the ability to interview patients of all ages, moods, and backgrounds, the technique of examining different body systems or all body systems and levels of illness, and finally the process of clinical reasoning that leads to your diagnosis and plan. Your experience with history taking and physical examination will grow and will trigger the steps of clinical reasoning from the very first moment of the patient encounter. Identifying symptoms and abnormal findings, you'll link findings to underlying pathophysiology or psychopathology, and you'll be able to establish and test a set of explanatory hypotheses. Working through these steps will reveal the multifaceted profile of a patient before you. At the onset or the outset of each patient encounter, you'll face the common question like, how much should I do? And should my assessment be comprehensive or focused? So for patients you're seeing for the first time in the office or the hospital, you'll usually choose to conduct a comprehensive assessment, which includes all the elements of the health history and a complete physical exam. In many situations, however, a more flexible, focused, or problem-oriented assessment is appropriate, particularly for patients you know well and they're returning for routine care, or those with a specific urgent care concern like a sore throat or knee pain. You will adjust the scope of your history and physical exam to the situation at hand, keeping several factors in mind. Please review the elements under a comprehensive and a focused assessment. As you acquire the techniques of history taking and physical exam, remember the important differences between subjective information and objective information or data. Remember, symptoms are subjective concerns, or they're what the patient tells you. Objective data or signs are one type of objective data, or information, and that's what you observe. So what you detect during the exam, laboratory information, and test data, all the physical findings or signs are objective data. I really appreciate the example they give on page 7 in your textbook. They talk about the difference between subjective and objective data, and the symptoms and the history from the chief complaint through the review of systems. Is that subjective data? So you're questioning them and their history of presenting illness. What do they say is wrong with them? Why are they there today? And the example they give is Mrs. G is a 54-year-old hairdresser who reports pressure over her left chest like an elephant sitting there, quote unquote, which goes into her left neck and arm. That is definitely what that patient is reporting. That's her concern. In contrast to the objective data is what you detect during the exam, the laboratory information and the test data, all the physical findings or signs. So in contrast, Mrs. G is an older, overweight white female who is pleasant and cooperative. Height 5 foot 4 inches, weight 150 pounds, BMI 26, blood pressure 160/80, heart rate 96 and regular, respiratory rate 24, and temperature 97.5 Fahrenheit. So those are objective data findings. When talking about the comprehensive adult health history, it's important to remember that when you are talking with patients, the health history rarely emerges in the order as I have listed here. The interview is typically more fluid, and you will closely follow the patient's cues to elicit the patient's narrative of the illness. You'll provide empathy and you'll strengthen rapport in that way. But these are the components of the comprehensive health history. And I want you to look at the very detailed chart on page 8 in our textbook. It really goes into detail related to these components. I want to direct your attention to the last one, however, review of systems. I do want you to remember that typically these are yes/no answers that the patient is given, and what you're doing is documenting the present or absence of common symptoms related to each of the major body systems that you reviewed. Okay, so to remember, that's subjective data. That is what the patient's response or answer is to your questions. The comprehensive physical examination is one of the major objectives of this course, and it certainly is of your 5010 clinical course that's really a co-requisite with 50009. You get the textbook and the didactic in this class, and then you are learning literally the technique of a comprehensive physical exam, and you'll also learn focused exam, but the comprehensive really includes a focused exam and some other advanced procedures and techniques. I just want you to realize that the first part of this course it's heavy with lecture and didactic and with practicing and learning the components of a comprehensive physical exam. What that does is it readies you to begin your clinical. You must get through this part of 50009, each part up until you take in 5010 the comprehensive head-to-toe examination. That readies you after successful completion to begin clinical. You will have 60 hours of clinical required in this semester out of 5010, and those are at the usually you take your head-to-toe comprehensive evaluation in about mid-semester. Okay, you can look on your calendar, but remember that enables you to have a level of competency so you can go in and do your 60 hours, but you've got to be on target because those 60 hours are not spread over the whole semester. They're at the last half of the semester, depending on where your clinical is and your hours that you're doing. So be very aware that this is our focus. And this is the directive, the main objective of 50009 and 5010 is to prepare you to be readied and competent to perform an advanced physical examination in clinic. Before you perform a physical exam, you'll set the stage, quote unquote, to begin an exam. You'll reflect on your approach to the patient. You'll adjust the lighting in the environment. Make sure you've got good lighting and it's warm enough. Check your equipment. Make sure the patient's comfortable. You'll observe standard and universal precautions, and you'll choose the sequence, scope, and positioning of the examination. And you'll learn these things very thoroughly during 5010, and we will augment that in this course. So there are 4 cardinal techniques of evaluation: inspection, palpation, percussion, and auscultation. And I definitely think the advantage, we're already nurses. You're becoming advanced practice nurses. So you are adding to what you already know how to perform. And I think you'll really appreciate that part of being an advanced practice nurse or taking this course. I want you to review on page 18 and 19 what the definitions of inspection, palpation, percussion, and auscultation are. I think that you probably know, but it's a very good idea to review these in the lens of an advanced practice nurse. The key to a thorough and accurate physical examination is developing a systematic sequence of examination. Organize your comprehensive or your focused exam around 3 general goals. Maximize the patient's comfort, avoid unnecessary changes in position, and enhance clinical efficiency. And in general, you're going to move from head to toe. But you will learn this in depth in 5010. And I think our Bates textbook does a great job in talking about head to toe. It will become so second nature as you become more experienced. With practice, you'll develop your own sequence of examination, keeping the need for thoroughness and patient comfort in mind. And just feel confident that that really will happen. It's important to also remember to examine from the patient's right side, moving to the opposite side or the foot of the bed or examining table is necessary. That's a standard position for the physical exam, and it has several advantages compared with the left side. Estimates of jugular vein pressure are more reliable. The palpating hand rests more comfortably on the apical impulse. The right kidney is more frequently palpable than the left, and the examining tables are frequently positioned to accommodate a right-handed approach. Left-handed students are encouraged to adopt a right-sided positioning. Even if it might seem awkward, the left hand can still be used for percussing or for holding your instruments such as your otoscope or your reflex hammer. This slide is simply a synopsis of the physical examination, head to toe, the comprehensive evaluation. If you will go into page 20 and go all the way through 24 in your Bates textbook, it will review it in detail. After completing the history and physical exam, you reach the critical step of formulating your assessment and plan. So you're supposed to use sound clinical reasoning to analyze your findings and identify the patient's problems. So the comprehensive health history and the physical exam form the foundation of your clinical assessment. The subjective data of the health history and the objective data from your physical examination and testing are primarily descriptive and factual. As you move to assessment, you go beyond description and observation to analysis and interpretation. You select and cluster relevant pieces of information, you analyze their significance, and you try to explain them logically using principles of psychosocial and bioclinical science. Your clinical reasoning process is pivotal to how you interpret the patient's history and physical exam. Single out problems identified in your assessment and move from problem and take it to the action plan. Now, does this not seem to be a huge leap? Here I've taken you through a very short, brief synopsis of the physical exam, and now I'm talking about clinical reasoning and assessment and plan. It's absolutely necessary that we do this because you have to be readied as proficiently as we can be. So I want you to look at those 3 types of reasoning for clinical problem solving. You're going to look at pattern recognition, development of schemes, okay, or the same story that's being repeated, the same findings or alike findings, application of relevant basic and clinical science. And then you really then move to shared decision making to develop a plan, because it's not just about you. You involve your patient or the family or both. So you identify and record a plan for each patient problem. The plan should make reference to diagnosis, treatment, and patient education. It is critical to obtain both patient agreement and encourage patient participation in decision making whenever possible. This whole process that I've reviewed is captured under the case of Mrs. N. Please read page 30 through 37 because it provides a wonderful example. You'll have other opportunities to work on cases that really reflect what Mrs. N's did, and perhaps not a comprehensive one, but a focused one. Finally, remember, a clear, well-organized clinical record is one of the most important adjuncts to patient care. Thank you.